pelvic inflammatory disease is usually through sexual transmission via the vagina and cervix. Could also be caused by gynecological surgical procedures, childbirth or abortion, a foreign body inside the uterus, for example IUCD. Contamination from other inflamed structures in the abdominal cavity, the appendix, gallbladder could also lead to pelvic inflammatory disease. And also blood-borne transmission, for example pelvic TB could lead to it. So basically all the structures could be affected: the fallopian tubes, the uterus, the ovaries, actually everywhere. So the infective organisms are anaerobes, endogenous aerobic organisms, sexually transmitted organisms too, mycoplasma and mycobacterium. So for sexually transmitted infections, the organisms implicated here are chlamydia, trachomatis, Neisseria gonorrhea. And for endogenous aerobic, we have streptococci, Haemophilus E. coli, and anaerobes we have Bacteroides, Peptostreptococcus, bacterial vaginosis, actinomyces, Israeli, and mycoplasma we have Mycoplasma hominis and urea plasma, and also Mycobacterium tuberculosis and Mycobacterium bovis. All these organisms could cause pelvic inflammatory disease. Predisposing factors as frequent sexual encounters, many partners, young age, early age at first intercourse as early coitus, and exposure immediately prior to menstruation, relative ill health and poor nutritional status, previously infected tissues like STDs and PID, and frequent vaginal douching. As you can see from the slides, there's a rare importance of treating PID, as it could lead to tubovarian abscess, as in a systemic upset too. Ectopic pregnancy could happen, as in 6 to 10-fold, and tube infertility. That's when the tubes are infected. It could be tubal, like I said. So 20%. Example, 2 episodes. Also in 40%, they had about 3 episodes of PID. Occurrence is very, very high, and male genital disease could also result to and lead to chronic pain, leading to hysterectomy. Acute PID, the presentation, well, normally there is severe abdominal pain, there is tenderness, low abdominal tenderness, there is mainly fever, malaise, vomiting, tachycardia, offensive vaginal discharge, irregular vaginal bleeding, bilateral adnexal tenderness, cervical excitation, tenderness, tubovarian mass, and Fitz-Hugh-Curtis syndrome. There's poor sensitivity and specificity, and the correct diagnosis is normally 45 to 70%. Presentation of chronic PID, normally there is chronic lower abdominal pain, backache, lower back pain, general malaise and fatigue, deep dyspareunia, dysmenorrhea, intermittent offensive vaginal discharge, irregular menstrual periods, also lower abdominal or pelvic tenderness, bulky tender uterus, and also infertility. There is a silent epidemic. In the differential diagnosis of PID, ectopic pregnancy, torsion or rupture, the adnexal mass, appendicitis, endometriosis, cystitis, or pyelonephritis. Laboratory studies, pregnancy test, complete full blood count, ESR, CRP, urinalysis, um, for gonorrhea, chlamydia detection, endogram stain cultures, ELISA, FA, DNA test, and test for TB, syphilis, HIV, pelvic ultrasound, codosynthesis if available, while laparoscopy is a gold standard. PIDs. Okay, so syndromic diagnosis of PID. The minimum criteria for the diagnosis: there is lower abdominal tenderness on palpation, bilateral adnexal tenderness, cervical motion tenderness, and no other established cause. Also, negative pregnancy test. Additional criteria: the oral temperature is more than 38.3 degrees Celsius. Also, normal cervical vaginal discharge, elevated erythrocyte sedimentation rate, elevated C-reactive protein, and WBCs on saline microscopy of the vaginal secretions too. There is a lab documentation of cervical infection with Neisseria gonorrhea or Chlamydia trachomatis. Definitive criteria: endometrial biopsy with histopathology evidence of endometritis, TVS or MRI, taken fluid-filled tubes or free pelvic fluid or tube-ovarian complex, and laparoscopic abnormalities consistent with PID. Management issues: for example, the inpatients and outpatients management. So when we give broad-spectrum antibiotic therapy without microbial findings, and that's not always so, and antibiotic treatment is adapted to the microbial agents identified later on by the various investigations to give oral or parenteral, so it depends to the standard management, and duration of the treatment is also associated with the choice of medications too, and associated treatment too. It depends on the state of the patient. So criteria for hospitalization: you have to exclude all surgical emergencies. If there is severe illness, nausea, vomiting, high fever, you have to do ovarian abscess, clinical failure of oral antimicrobials, inability to follow tolerate oral regimen, pregnancy, immunodeficiency, HIV with low CD4 count, immunosuppressive therapy. All these you have to admit and manage the patients closely. So antibiotic therapy: for gonorrhea, you give cephalosporins, quinolones, and also chlamydia, you give erythromycin, doxycycline, and quinolones, not cephalosporins. Anaerobic organisms can give metronidazole, clindamycin. In some cases, can give doxycycline, and beta hemolytic streptococcus and E. coli. Penicillin derivatives such as cyclines and cephalosporins. E. coli is most often implicated over here. Parenteral regimen A can give cefuzitin 2 grams IV 6 hourly, or cefuzitan 2 grams IV 12 hourly, or doxycycline 100 milligrams POIV 12 hourly, plus metronidazole, clindamycin till as to ovarian abscesses. That's what you normally give. Regimen B can give high dose clindamycin. So high dose clindamycin Give 900 milligrams IV 8 hourly. Gentamicin loading dose 2 milligrams per kilogram IV or IM. The maintenance dose of 1.5 milligrams per kilogram IV or IM 8 hourly. Okay, so let's review the antibiotic regimen again. For parenteral regimen A, we give cefuroxime 2 grams IV 6 hourly or cefuroxime 2 grams IV 12 hourly. Doxycycline plus doxycycline 100 milligrams pure IV 12 hourly plus metronidazole or clindamycin normally in tube ovarian abscess. And parenteral regimen B can give clindamycin 900 milligrams IV 8 hourly. Gentamicin loading dose 2 milligrams per kilogram IV or IM with a maintenance dose of 1.5 milligrams per kilogram IV or IM 8 hourly. Alternative parenteral regimen: give ofloxacin 400 milligrams IV 12 hourly, or you can give levofloxacin 500 milligrams IV once daily, with or without metronidazole 500 milligrams IV 8 hourly, or ampicillin or sulbactam 3 grams IV 6 hourly, plus doxycycline 100 milligrams orally IV or IV 12 hourly. Outpatient antibiotic regimen: A, normally give ofloxacin 400 milligrams twice daily for 14 days, or levofloxacin 500 milligrams once daily for 14 days, with or without metronidazole 500 milligrams twice daily for 14 days. Outpatient antibiotic therapy regimen B, give ceftriaxone 250 milligrams IM once, or cefuroxime 2 gram IM. Then probenecin 1 gram PO once, plus doxycycline 100 milligrams PO and BID as 12 hourly for 14 days, with or without metronidazole 500 milligrams 12 hourly for 14 days. The CDC recommendation: there's no efficacy data comparing the parenteral with the oral regimen. Clinical experience should guide decisions on the regimen transition to oral therapy. Until the regimens that do not adequately cover the anaerobes have been demonstrated to prevent sequelae, until they've been proven to be effective, you should provide other regimen that will fight against the microbes, the anaerobic, and also provide anaerobic coverage. So when should treatment be stopped? The parenteral treatment should be changed to oral therapy after 72 hours with substantial clinical improvement, and continue oral therapy until clinical and biological signs, for example leukocytosis, ECR, CRP, disappear or for at least 14 days. And if no improvement, additional diagnostic tests and surgical intervention for pelvic mass abscess rupture should be dealt with. Associated treatment: rest at the hospital, at home, abstain social abstinence until care is achieved. An anti-inflammatory treatment too is given. For special situations, pregnancy, augmentin or erythromycin, hospitalizations, concomitant HIV infection, patients should be admitted, giving the IV antivirals and the antimicrobials, more likely to have pelvic abscesses, also respond more slowly to antimicrobials, as in HIV infection. So it requires changes of antibiotics more often. Concomitant candida and HPV infections could occur too. Surgery in PID. The indications are acute PID, ruptured abscess, failed response to medical treatment, and uncertain diagnosis. A chronic PID, severe progressive pelvic pain, repeated exacerbations of PID, bilateral abscesses more than 8 centimeters diameter, bilateral urethral obstruction. The surgery in PID. Timing of surgery. When there is no improvement within 24 to 72 hours, increasing as 2 to 3 months after acute stage, and type of surgery could be colpotomy, um, percutaneous drainage, or aspiration, exploratory laparotomy. Extent of the surgery, conservation if um, fertility is desired, UL, unilateral, bilateral, salpingo-oophorectomy, total abdominal hysterectomy, drainage of abscess at laparotomy, and identification of the uterus too. The management of sex partners, yeah, examination and treatment if they had sexual contact with patients during the 60 days preceding the onset of the symptoms in the patients. Empirical treatment with regimen effective against C. trachomatis and N. gonorrhea. A prevention, how the primary prevention, secondary prevention, and tertiary prevention. Primary, like sexual counseling, practice safe sex, limit the number of partners, avoid contact with high risk partners, delay the onset of sexual activity until more than 16 years. Barrier and oral contraceptives reduce the risk of developing PID. Secondary prevention, screening for infections in high risk, so rapid diagnosis and effective treatment of STDs and lower tract and urinary tract infections. Tertiary prevention, early intervention, and complete treatment too. So basically, PID in women is a silent epidemic and can have serious consequences. So be aware of the limitations of the clinical diagnosis too. Adequate analgesia and antibiotics should be given, and proper follow-up is essential. The treatment of the male partner is very, very important. Educational campaigns for young women and health professionals should be done. Prevention by appropriate screening for STD and promotion of condom usage too.